Hello. Today, I will share my presentation.
Yes, please share your presentation.
I have shared my presentation. Can you see this now?
Yeah. Head out.
Okay. Can I start the presentation?
Please on presentation mode. Look.
Thank you very much. Thank you very much for inviting me to present
on presentation.
My lecture at today conference. My presentation is on screening for cytomegalovirus infection in pregnant women and their fetuses. Cytomegalovirus causes the most common congenital infections in the world. It is diagnosed in approximately 0.5 to 1.0% of all live-born neonates. Infections caused by cytomegalovirus are mostly asymptomatic. However, symptomatic infections are observed in 10 to 15% of cases with varying clinical signs. On the picture, we see that between 20 to 60% of pregnant women are susceptible to CMV at conception. Of this, between 1 to 4% of seronegative women will acquire CMV during pregnancy, and on average, between 30 to 50% of infected women will transmit the virus to the fetus. The lowest transmission rate, approximately 35%, occurs when the maternal infection is in the first trimester, and as pregnancy progresses, the transmission rate increases to 73% for women who acquire CMV infections in the third trimester. Of infants infected in utero, approximately a third will have symptoms or develop severe neural impairment. This neonatal disease rate is probably highest for children of women who have had a primary infection in the first half of pregnancy, but definitive data on this point are still lacking. Primary maternal infections occur in approximately 1 to 4% of seronegative pregnant women. The risk of vertical transmission of CMV following a primary maternal infection has been estimated to be approximately 30 to 40%. In addition, although maternal primary CMV infections occurring early in pregnancy are transmitted to only approximately 20% of exposed fetuses, early prenatal CMV infections are associated with severe symptomatic congenital CMV infections at birth and with severe and long-term sequelae. Conversely, maternal infections in the third trimester have a maternal fetal transmission rate of approximately 75%. However, symptomatic infections are uncommon and are generally less severe when they do occur. For primary CMV infection in pregnancy occurs at a rate of approximately 1 to 13%. The vertical transmission rate of CMV following a non-primary maternal infection is reported to be approximately 0.2 to 2%, and symptomatic congenital disease is diagnosed in less than 1% of known cases. However, the biology of these infections or why maternal immunity from previous infections is unable to prevent the occurrence of all congenital infections remain unclear. Risk factors for congenital CMV infections are both biological and clinical. Among them, the following risk factors were reported. For example, a low CMV-specific IgG avidity index, an absence of antibodies against pentameric complex, and a low CMV-specific IgG avidity index, higher incomes after primary infections, a younger age and unemployment after non-primary infections, as well as fewer flu-like symptoms, fetal ultrasound abnormalities, and preterm delivery at below 34 gestational weeks in high-risk populations. CMV IgM antibodies are generated following a primary CMV infection. More specifically, when examining CMV IgM kinetics following a primary infection, peak levels are seen within the first 1-3 months, after which IgM titers decrease sharply within 2-3 months after the onset of infection and fall below the threshold of detection within 12 months. Following an initial CMV infection, the host begins to produce IgG antibodies to the virus within 1-2 weeks, and the production of CMV-specific IgG antibodies continues lifelong. IgG antibodies with low antigen avidity are present during the early weeks following a primary infection. Subsequently, IgG avidity gradually increases with time, reflecting the maturation of the immune response, and high IgG avidity then persists for many years. IgM levels below the threshold of detection are observed within 12 months from the onset of infection. Primary CMV infection predominantly is diagnosed in pregnant women based on a positive CMV IgM antibody test. However, noteworthy, CMV IgM antibodies are not unique to primary CMV infections. High false positive rates are reported regarding primary infections. Production of CMV IgM antibodies is also observed during reactivation or reinfection. 5 false positive results are also caused by aberrant and non-specific cross-reactivity with several viruses, for example, herpes simplex virus, varicella zoster virus, and Epstein-Barr virus infections, and by an interference from autoimmune antibodies like rheumatoid factor. CMV IgG seroconversion is still the most reliable evidence of primary CMV infection. However, preconceptional serological screening for CMV is not recommended in many countries for practical reasons related to health economics or the uncertainty of serological testing. The assessment of CMV IgG results is recommended at the beginning of the second trimester to identify cases of seroconversion, and in the third trimester to detect cases of late seroconversion. Low IgG avidity is observed in the early weeks after primary infection. It is an essential tool for determining the onset of CMV infection and a reliable commercial procedure for differentiating primary from non-primary infections in pregnant women. IgM antibodies combined with low IgG avidity indicate a recent primary infection. Low IgG avidity is also falsely presented in cases of preconception infections. Some limitations of CMV IgG avidity assays were also reported, and they include various thresholds for low and high avidity among the different commercially available kits. Moderate to high IgG avidity values after 21 weeks of gestation cannot rule out primary infection. A high IgG avidity index was found in the first trimester of pregnancy and identifies past infections. Long-term presence more than 18 weeks of low IgG avidity may result in misdiagnosis of primary CMV infection, especially when CMV IgMs are also identified. Among fetal ultrasound abnormalities observed in congenital CMV infections are, for example, ventriculomegaly, microcephaly, different cranial abnormalities, other symptoms, other signs associated with CMV. With congenital CMV also include placental or amniotic fluid abnormalities, as well as extracranial abnormalities. The presence of CMV infections in pregnant women, as well as in their fetuses, is determined based on CMV serology. When patients are seronegative both for IgG and IgM, we can say that they are uninfected or early infected. In case of seronegativity for IgG and seropositivity for IgM, this determines very recent infection or maybe false positive due to other viral infections. In case of IgG seropositivity and IgM seronegativity, we can say about a past infection or non-primary infection. When pregnant women are seropositive both for IgG and IgM antibodies, it is determined a past infection or non-primary infection, but also it can be the primary infection. In case of low IgG, in case of high IgG avidity, but in case of low IgG avidity and seropositivity for both types of antibodies, we say about recent primary infection, but also non-primary infection. Markers of congenital CMV infections include routine fetal ultrasound examination in the absence of routine CMV serology during pregnancy. Symptomatic congenital CMV infection reported very rarely in patients with a history of infection. low detection rate of non-primary CMV infections by maternal CMV IgM serology, some cases of congenital symptomatic CMV infection found in maternal primary infection seronegative for CMV IgM, occasionally observed a quick clearance of specific IgM antibodies and high IgG avidity within 90 days of the onset of primary CMV infection, the absence of maternal CMV specific IgM in cases of negative responses after primary maternal infection occurred very early in pregnancy. Considering the kinetics of HCMV or CMV, HCMV means human cytomegalovirus. Considering the kinetics of HCMV specific IgM clear antibody, there are three groups of patients, about 5% of women showing early clearance, about 35% of them testing IgM positive for 6 months, and about 60% having a long-lasting IgM persistence. The format of serological assay, ELISA versus CLIA, is crucial to detect CMV-specific IgM antibody, with the CLIA being more sensitive and the ELISA being more specific. Different avidity index results can be obtained using assays based on different formats, such as CLIA versus immunoblotting. In the presence of CMV anemia, a primary infection should be consistently taken into consideration. The presented picture summarizes the proposed algorithm for the management of fetal infection following maternal primary infection in the first trimester of pregnancy. On this picture, we see the comparison of the reported outcomes in children born after first trimester primary infection following natural history, with those born following CMV serology screening in the first trimester and prenatal diagnosis. The proportions of neurological sequelae in both groups, 32% versus 2.6%, clearly suggest that screening is likely to identify the most severe cases and give parents the choice of terminating the pregnancy or anticipating the birth of a potentially severely handicapped child. Thank you very much for your attention.